For our next section, we're going to talk about the parathyroid glands, and especially in that context with the parathyroid glands, we're going to talk about calcium metabolism, especially hypercalcemia and hypocalcemia. Let's talk about some general issues based on this figure about calcium metabolism, and we're going to talk about the key players that are involved in calcium metabolism and the key players that sustain a normal calcium level in our serum. So the most important hormone, of course, is parathyroid hormone, this right here. This is secreted by the parathyroid glands, PTH, and it stimulates the osteoclast in the bone, basically to break down bone and release calcium into the serum, because remember, parathyroid hormone's main process is to keep the calcium in the serum stable. Otherwise, if the calcium drops, you would go into tetany and develop tetany and so forth. But so parathyroid hormone stimulates the osteoclast, and you break down bone and release calcium into the serum, and then it does a couple of other things. It increases distal tubular reabsorption of calcium from the kidney. And then another very important thing that it does, this one we have to know about right here, the effect on phosphate. Now, even though it reabsorbs calcium, what it does in the kidney is it increases the secretion of phosphate because it blocks the reabsorption of phosphate. So really, parathyroid hormone increases calcium in the serum many ways, either by activation of osteoclasts or by affecting the kidney. And what it does to the phosphate is it decreases phosphate in the serum, basically by blocking reabsorption of phosphate through the kidney. So the second player that's very important in calcium metabolism is vitamin D. And vitamin D plays a big role in calcium metabolism because it increases calcium absorption from the GI tract, and we're going to talk about that. But first, let's talk a little bit about how vitamin D gets absorbed. And there's two processes. One process is through the skin. So you absorb vitamin D through the skin, through the sunlight. So people that don't have access to sunlight, they're living in long-term facilities that are bedridden for a long time and don't go out into the sunlight, you decrease the amount of vitamin D that you absorb from the skin. And this has been the focus of some studies in the last 4 or 5 years that have shown that people living in older patients, living in long-term facilities, living in basically that are bedbound, they don't have access to sunlight, get a relative vitamin D deficiency. So think about that. And then the second way that we absorb vitamin D is through the gut, through our GI tract, through food, along with the other lipid-soluble vitamins, right? Vitamin A, vitamin E, vitamin K. And what you need is you need pancreatic enzymes for that. You need vitamin D in the food. Then you need pancreatic enzymes. So people with chronic pancreatitis, for example, can't absorb vitamin D, and they get a vitamin D deficiency because you need the pancreatic enzymes to basically absorb it in the small bowel. And then the third thing that you need is, after you have enough of vitamin D in the food, after you have pancreatic enzymes, you need an intact small bowel surface to be able to absorb vitamin D. So patients, for example, that have celiac sprue, tropical sprue, Whipple's disease, proximal Crohn's disease, they have malabsorption syndromes that affect vitamin D, and these patients develop vitamin D deficiency. So what do we need to absorb vitamin D? We need sunlight to be able to get it from the skin. We need it from our food. You need vitamin D from your food and your milk products and so forth. We need pancreatic enzymes to be able to absorb it, and then we need an intact small bowel surface to be able to absorb it. So think right there, you have about 3-4 etiologies that could cause vitamin D deficiency, right? No access to sunlight, right? Pancreatic insufficiency, food, if people are not eating the right food, and then number 4, small bowel disease like celiac sprue. Think about that, because that would be your differential diagnosis of vitamin D deficiency. After we absorb enough vitamin D, we still got a little bit way to go. We need to hydroxylate it at 2 different sites in order to be able to have the active type of vitamin D. So the first site is right here in the liver, the 25th site. You activate it through the liver, and now it's called 25-hydroxy vitamin D. And then the clinically most important site is the first site right here. So after you hydroxylate it in the liver, it goes to the kidney right here, and you hydroxylate it at the one site. So now it's called 125 vitamin D, hydroxy vitamin D, and now it's activated, and now it works, and it's supposed to do what it's supposed to do with calcium metabolism. So basically, beyond all the stuff we talked about the skin, about the GI tract, you need an intact liver to hydroxylate your vitamin D, and an intact kidney to be able to hydroxylate it and activate it. So right now you should know a good differential diagnosis about possible vitamin D deficiency. You think about skin disorder, people that don't have access to sunlight and they don't absorb it from the skin. Think about GI malabsorption. Think about cirrhosis. Think about kidney dysfunction. Out of these two, liver disease and kidney disease, the one that's most clinically important is the renal causes. The reason is because even with mild and moderate renal disease, you could have malabsorption, or I shouldn't say malabsorption, non-hydroxylation of vitamin D, so you don't have active vitamin D, even with moderate disease. So in people with glomerulonephritis, for example, or any other type of form of chronic kidney disease, even before their creatinine starts to increase, even before they become end-stage renal disease, they have relative vitamin D deficiency. So clinically, in terms of hydroxylation, the renal causes are much more important than the liver causes. The liver causes, you only get vitamin D deficiency only when you have end-stage liver disease, end-stage cirrhosis, and at that stage, vitamin D deficiency will probably be one of the least problems that this patient has with cirrhosis, because they have a ton of other problems. So clinically, what's most important that we see in clinical practice is the renal causes in terms of hydroxylation of vitamin D. So once you absorb it, then you hydroxylate it, now you activate it, now you have active vitamin D. And what does your vitamin D do? Well, your vitamin D increases calcium reabsorption from the intestine. So the food that you get, the vitamin D that you get from your food, it increases reabsorption from the GI tract. It also probably increases reabsorption from the kidneys, from the tubules. So kind of an effect like parathyroid hormone. The only interesting thing that it does that's different from parathyroid hormone, and this is very important clinically because we're going to touch on this a little bit later, if you look right here, the effects of vitamin D, right at this spot right here, what it does is it increases proximal tubular reabsorption of phosphate. So vitamin D not only increases calcium in the serum, but it increases phosphate in the serum through reabsorption in the kidney. Remember, parathyroid hormone does the opposite. It increases calcium in the serum, but it decreases phosphate in the serum. This is very, very important in terms of assessing causes of hypocalcemia. Very important point. The third player here is calcitonin. Now, calcitonin is secreted through the calcitonin cell, the parafollicular cells in the thyroid, and it seems to be the hormone that really what it does is it puts calcium onto the bone. It puts calcium onto the bone. So basically, if your calcium serum decreases because calcium deposits onto the bone with calcitonin. So it does the exact opposite of what really parathyroid hormone does to calcium in the serum. It puts calcium onto the bone and basically decreases calcium in the serum. Now that's why we like to use calcitonin in certain other diseases where calcium deposition onto the bone really matters. For example, we treat hypercalcemia with calcitonin because it puts calcium to the bone. We also treat osteoporosis with calcitonin for the same reason. It enhances, right, calcium onto the bone. So those are your three main players. And then I want to talk about just a couple of things more before we talk about hypercalcemia. I want to talk about this calcium that we measure in the serum right here. The calcium that we measure in the serum is bound to albumin. About 40% of the calcium that we measure in the serum is bound to albumin. This is very important because usually when you get a calcium from your comprehensive chemistry panel or from your Chem 7, your chemistry panel and all that, your basic metabolic panel, that calcium is not ionized calcium. It's ionized calcium, that's about 60%, and then the 40% is bound to albumin. Now you can ask for a specific study that only measures ionized calcium. It's usually done only specific labs, and it's difficult to do and it's expensive. So when we get calcium back routinely, unless you ask for the specific ionized calcium, it's bound to albumin. So any effects in albumin in the serum, any effects, anything that would decrease albumin in the serum decreases total calcium, the stuff that we get that we measure. So for example, a patient with nephrotic syndrome develops hypoalbuminemia. This patient will have a total calcium that's decreased. The ionized calcium, though, will probably be normal, can be normal. So you could adjust and really figure that out. So for example, we know that for any drop in albumin, for every drop in albumin of one single point, 1 milligram per dl, below normal, the amount of calcium is decreased by 0.8. So that's, we have to remember that number. So let me say it again. A decrease in albumin of a single unit, a single point, decreases your calcium by 0.8. I'm talking about albumin below normal. A normal albumin level is 4 milligrams per dl. So for every single drop of a unit below 4, the total calcium drops by 0.8. So every time we see hypocalcemia, and we're going to talk about this a little bit later, we have to adjust. If there's any hypoalbuminemia, we have to adjust for this, because sometimes the patient doesn't really have a low calcium. It's because the albumin. The second thing is that I want to point out to you is that basically calcium and phosphate are under constant ratios. So a big increase in phosphate decreases your calcium and vice versa. And we're going to see this is very important in end-stage renal disease, where phosphate levels, patients with end-stage renal disease can't get rid of phosphate, and your phosphate increases in the body. And what this does is, because these two are under a constant ratio, this decreases the calcium in the serum. That's very important. So another factor that plays in what your calcium, what your serum calcium does, is the amount of phosphate. When it's normal, it doesn't affect it that much, but when the phosphate is really high, what that does is it decreases the amount of calcium. So I want you to remember that. So that's what we need to know about calcium metabolism and the parathyroid hormone levels. And now we want to talk a little bit about hypercalcemia. Now, hypercalcemia is a common clinical scenario, and we see it commonly, and it's a big, differential diagnosis in making the diagnosis, because it's a bunch of very different diseases that cause hypercalcemia. Now, the most common one is hyperparathyroidism. That's why we have it number 1 on this list here. The most common cause of hypercalcemia, all around, if you go across the board, with all causes of hypercalcemia, hyperparathyroidism is by far the most common one. And hyperparathyroidism, most of the time, is pretty benign. What I mean by that is the hypercalcemia is mild, maybe moderate, so you have minimal symptoms. In fact, when we talk about hyperparathyroidism later, you're going to see that maybe about half of these patients have really no symptomatology at all. They're asymptomatic, so this is picked up usually by chance just by doing a lab test and finding hypercalcemia. So the number one cause of hypercalcemia across the board in all cases of hypercalcemia is hyperparathyroidism, primary hyperparathyroidism. The second most common one is malignancy, and that's the big differential when we see people with hypercalcemia, where we say we have to exclude malignancy because that's also a pretty common cause. Now, malignancy causes severe hypercalcemia. If it's usually metastatic disease or aggressive disease that has caused the hypercalcemia, so the hypercalcemia of malignancy is usually severe. These patients usually have a lot of symptoms, and if they don't have symptoms initially, they will develop symptoms later unless you could treat the cancer, which is sometimes not treatable in this case because it's already metastasized. If you take cases of patients admitted to the hospital with severe hypercalcemia, so you take just that specific population, patients admitted to the hospital with severe hypercalcemia, the number one cause of those cases is malignancy, hypercalcemia of malignancy. So malignancy causes malignant hypercalcemia, a lot of symptoms, moderate to severe disease, not like hyperparathyroidism. There are two ways that malignancy could cause hypercalcemia. The number one cause in terms of frequency is the second one right here, is bone metastases. So for example, you have multiple myeloma, or you have metastatic breast cancer, and because of the metastatic disease to the bone, they activate locally tumor necrosis factor, interleukins, leukotrienes. They activate the osteoclasts locally, the metastatic sites, and basically what you do is you have release of calcium from the bone due to the metastatic sites. So this is, in terms of frequency, this is the most common form of hypercalcemia that we see with malignancy. But the other one that we also see, which is very interesting, and they ask us a lot on the boards for, is this thing called parathyroid hormone-like peptide that is secreted commonly from squamous cell cancer. Squamous cell cancer usually of the lung, but you could also have squamous cell cancer of the esophagus and head and neck area. So these squamous cell cancers secrete this parathyroid hormone-like peptide that works just like parathyroid hormone. What does parathyroid hormone do? It activates the osteoclasts to break down bone and release calcium into the serum. So it works exactly like parathyroid hormone to basically increase calcium in the serum, and that's how we get the hypercalcemia. The other interesting thing about squamous cell cancer is that it doesn't metastasize. It doesn't metastasize, it grows locally. It invades local structures, even when it's in the lung. And so you know that basically when it causes hypercalcemia, it's hardly ever through metastatic disease. It's usually through this thing called parathyroid hormone-like peptide. Now, one important other thing about this peptide, when we measure parathyroid hormone in the serum, the one that we're really measuring is the endogenous one that we get secreted from the parathyroid glands. We're not really measuring parathyroid hormone-like peptide. So the assay that you measure in the blood could tell the difference between a like peptide and the one that you secrete from the parathyroid glands. So basically, if I check hypercalcemia, a patient with hypercalcemia, and his or her